and I'm feeling fine. Can't wait to come out of ISO. A couple symptoms left, so just want to make sure you can hear me.
Sorry to hear, but yeah, we can hear you pretty well.
Good. No, I feel fine. I'm going to get started. You think I should get started?
Yeah, it's 11:03. I think we've got a good group here.
Okay. Share screen.
Cute baby, Alden.
Mm-hmm. She wants to learn about mild cognitive impairment.
So
Okay.
the talk I've prepared today was really notes to myself on mild cognitive impairment because I really didn't know as much as I should have known, or you might expect I knew about the concept of mild cognitive impairment before working on things like the HCAP algorithm. And I'm happy to share these with you, and I appreciate the invitation from Alden to do so. I'm going to cover background on the meaning and measurement of mild cognitive impairment, some approaches to operationalizing the mild cognitive impairment concept, and possible approaches to mild cognitive impairment in field research. And I'm sure we'll have time for discussion. I'm going to start with the bottom line up front, which is to review the concept of MCI. It's conceptualized as an intermediate state between normal cognition and dementia. It is a pathological condition. It is distinct from normal cognitive aging, and it is more than just low cognition. The concept's popularizer, Ron Peterson, has been steadfastly resistant to attempts to operationalize the diagnostic criteria and believes that the diagnosis can only be made by a clinician and there is substantial subjective leeway necessary to arrive at the diagnosis of MCI. Attempts have been made to operationalize the criteria of varying quality. I define quality the extent to which the operationalizations remain true to Peterson's criteria. Some recent high-quality operationalizations have appeared, including those in NAC and those in HRS-HCAP. Pat myself on the back. And then these operational definitions are not directly transportable to other studies that use different data collection procedures, but the conceptual definitions are transportable.
Rich, can I ask a question on this slide? When you say that MCI is a pathological condition, that implies to me that you think that there's an underlying pathology to it. So we also think that dementia is a pathological condition, but there are probably multiple pathologies. Are there multiple pathologies of MCI?
Probably.
Okay.
But I don't know that I encountered that in my literature review, Alden.
I think I can
Okay.
add to that. I think, yeah, because the idea is, right, that MCI and dementia are like one in the same, right? That they're part of this continuum from normal MCI dementia that's part of a neurodegenerative process, right? And so that's like the idea behind MCI, that it's like if someone's diagnosed, that's why like with Ron Peterson's emphasis on the clinical side, that if you're diagnosing somebody with MCI, it's because you're thinking there's a neurodegenerative process or some pathological process happening that will lead to a dementia. Is it going to be Alzheimer's disease? Is it going to be a PPA? It'll vary, obviously, but I think that's the conceptual idea of it.
Okay.
Okay.
Thank you, Miguel. Here's my artwork. This is a timeline I put together for major, what I consider to be major antecedents and events in the evolution of this concept of MCI. I got a couple important milestones on here. I'm going to be starting my presentation in 1997 with a review of a paper by Ron Peterson, who I will say is the rediscoverer or repopularizer of this concept of mild cognitive impairment. But there were ideas along the lines of, or adjacent to, this concept of mild cognitive impairment that existed well before 1997. Probably one of the earliest was this concept of benign senescent forgetfulness in 1962. You can see in this name that part of the idea is that it's benign, which means it's not a pathological condition, and it's senescent, which means it's associated with aging, which is quite distinct from the idea of mild MCI as being distinct from normal cognitive aging and the pathological condition. So that's why it's got that paper gets a little yellow dot instead of a purple dot. I'm keeping the purple dot for this MCI as a preclinical dementia type syndrome. And I got green for some other concepts too. 1982, though, saw the publication of the clinical dementia rating, which did have an intermediary concept in it. So that gets a purple box. Also in 1982 was Barry Reisberg work in mild cognitive decline. And he had his own scale, geriatric deterioration scale in 1992. And he did a lot of early work in this concept and probably doesn't get the recognition that he needs as a early thinker in the mild cognitive impairment area. This concept of age-associated memory impairment was articulated in 1986. In 1994, we get age-associated cognitive decline, and the DSM, it gives us the mild neurocognitive disorder. And in 1997, we get cognitive impairment neurodementia. So every 5 to 10 years, we get a new term, a new set of criteria, varying degrees, to identify patients or research participants that fit into different categories. But for whatever reason, the Ron Peterson concept of MCI has really stuck. In 2004, ADNI launches, and Ron Peterson was a part of the investigator group, and the concept of MCI was a very important part of the ADNI research design, a major stratification variable, and I'll talk more about that as we go on. And by 2009, we get some attempts to do what I think are more rigorous operationalizations of the MCI concept. And these I attribute to Jack and Graves and Bondi. And this work appeared in 2009, and some other recent work in 2020 is really formalizing this operational approach to identifying MCI. And it is done in the concept of also identifying dementia. And that fits in with this idea that MCI is an intermediary step between normal and dementia. So we don't define MCI without also identifying dementia, as I'll explain. So, long series of slides with quotes from papers. I see there's things in the chat. Alden, you'll have to watch the chat. I'm not going to watch it while I'm going to talk, but if I need to stop, let me know.
I'll let you know if it's relevant.
So, In his 1997 paper in International Psychogeriatrics, Dr. Peterson lays out his definition of the conceptualization of MCI. Presumably, patients who ultimately develop AD started with cognitive function that was quite normal. During their transition to AD, it is likely like they passed through a stage of mild cognitive impairment. The task for the clinician is to identify patients in this mildly impaired state. Mild cognitive impairment can be defined as a state in which a single cognitive function, usually memory, is impaired to an extent that is greater than would be anticipated for age, yet the patient does not meet criteria for dementia. So here we have an intermediate stage, emphasis on the clinician as the mechanism by which the classification of patients occurs, and also selective impairment, and specifically selective memory impairment. More quotes and a cartoon, but the quote first. The diagnostic criteria we have used to define mild cognitive impairment include the following. A, complaint of defective memory. B, normal activities of daily living. C, normal general cognitive function. D, abnormal memory function for age. And E, absence of dementia. Most of these patients have degrees of memory impairment that are 1.5 to 2 standard deviations below these individuals of similar age, although these patients are functioning relatively normally with regard to other general cognitive functionings. So, although there is a description of degrees of impairment in terms of standard deviation units, Peterson and colleagues are not using that definition as a criteria for classification. It's merely a descriptive term. The classification was done clinically, and the observation of degrees of differences is something that happens after the clinical assignment. So that those are not cutoffs. The cartoon, I'm going to reuse this motif in upcoming slides, but we have a dimension of cognitive impairment on the x-axis here, whoops, and no, the x-axis is actually defining grades of functional impairment, and the y-axis is describing differences in cognitive impairment. So we have increasing cognitive impairment as we move up this y-axis, and increasing functional impairment as we go across the x-axis. And that's how we sort people into groups. Last quote page from this paper. Patients so identified may be an ideal population for intervention because they are reasonably healthy, and therapeutic retardation of the clinical progression would have a significant impact both on individuals and on society in general. These patients do not have sufficiently severe pathology to render therapeutic modalities ineffective. This is a very hopeful claim on the importance of identifying and targeting for treatment patients with mild cognitive impairment. A new paper. This is a paper from 2004 on from the Journal of Internal Medicine, and Ron Peterson is repeating his resistance to operationalizing criteria for MCI. And Ron Peterson, who introduced the concept of MCI to the field in 1997, 7 years later, writes in a paper, there is no agreement in the field on a single set of criteria for MCI. And this aspect, I almost said shortcoming, but I don't think Ron Peterson would agree this is a shortcoming. I think he would think this is a feature. But this feature of the concept of MCI has been noted as unresolved, even going on in 2012 by Karen Ritchie and her colleagues, writing in International Psychogeriatrics. That's what the bubble quote's about. Okay. Same paper, 2004, another quote. The criterion of objective memory impairment for age has been a major source of contention in the literature. This criterion can be fulfilled with the assistance of neuropsychological testing, but once again, no particular test or cutoff score is specified. Rather, this is left to the judgment of the clinician in the appropriate clinical context. So very clearly, the absence of Ron Peterson to articulate specific neuropsychological testing criteria for the classification of people according to MCI is a feature. It's a strength of his definition of MCI, at least as he perceives it, because it is a diagnosis that's made with clinical judgment and is not something that merely requires poor performance on a cognitive test. Fast forward to this is actually around the same time. Ron Peterson was the protocol principal investigator of the ADNI project when it started in the year 2000. Michael Weiner was the project director. And I went through the protocol manual for ADNI and I made this table that summarizes the classification of persons according to cognitively normal, mild cognitive impairment, and mild AD dementia. This is actually where I started my literature review in the concept of MCI, because I was interested in working up a definition of mild cognitive impairment for another research project. And I thought, what better place to start than what was used in the ADNI project? And this is where I discovered that the classification of people according to normal, MCI, and dementia for ADNI was not done with a strict algorithm on the basis of cognitive testing, but it was done at the time of enrollment by the study partner or enrolling clinician. So patients came into ADNI assigned to these categories. They were not put into these categories after enrollment into ADNI. But here's a list of the inclusion criteria and how they fell out in the ADNI study. So now I'm going to go through the table. People who are cognitively normal were participants without subjective memory complaints verified by a study partner beyond what would be expected for age. People with mild cognitive impairment expressed subjective memory concern reported by a participant or recalled by a study partner or a clinician. Same for mild AD dementia as MCI. Cognitive test scores were involved or described in these ADNI participants. And here are score ranges for people falling into normal, into the cognitively normal group and the abnormal function group, and stratified further by MCI and mild AD dementia. And the thing I want to point out is that across these categories, the score ranges are overlapping. So somebody with a score of a 4, logical memory 2, could be normal or abnormal if they were in the 0 to 7 years of education level. Somebody with a score of 2 could be in the mild AD dementia group or the MCI group. It's not a cut point. It's not criteria. It's just a descriptive. These groups are overlapping. The same applies to mini mental state examination scores. The same applies to CDRs. The adjacent diagnostic categories have overlapping cognitive performance ranges. And this means that I think this is probably a good reflection of reality and something a clinician would be very comfortable with and using as a guide to making their diagnosis. Their diagnosis is based on their base clinical judgment after interacting with the patient and a family member. It's not strict adherence to an algorithm based on scoring.
So wait,
And yeah,
sorry, can I recap? So you're saying that people came into ADNI in one of these groups. ADNI didn't classify people. That's way different than what my understanding was. So did the I guess the clinician at the ADRC assign a classification for the person and then they were enrolled in ADNI? Is that what happened? Based on these criteria?
I think my understanding is, and maybe there's somebody here who knows, I'm sure there's somebody who knows it better than I do on the call and in the world, but my understanding is people were recruited from the centers. The recruitment interview included a clinical interview. The clinic with a clinician, with the doctor, and the diagnosis, the classification was made during that interview. And these descriptive statistics that you see tabulated for baseline participants according to ADNI are not to be inferred as a diagnostic algorithm that was used to classify people according to cognitive category diagnosis.
Oh, interesting.
Isn't it interesting? I could have it totally wrong, but I'm pretty sure that's the way it works. And you can find it out in the protocol document. This is online. So I'm going to have to look elsewhere for operationalizations of the MCI criteria. And I've heard rumors from my colleagues about the Bondi criteria. And so I went looking for what the Bondi criteria are. I think I've got the papers that describe the Bondi criteria. Probably the first one is this 2014 paper, but I'm going to talk about a 2020 paper because it's more recent and it was easy for me to get access to and provide, and it had some really interesting data and results to share. Excuse me. So this paper from Graves and colleagues, where the title was Evidence for the Utility of Actuarial Neuropsychological Criteria Across the Continuum Normal Aging, Mild Cognitive Impairment, and Dementia. This was in the Journal of Alzheimer's Disease, published in 2020. Had a nice formal, operational, neuropsychological test-based classification of people according to normal MCI and dementia. I just want to have a little footnote or a little bar that says these are called actuarial neuropsychological criteria. And we're probably gonna want to be very careful to describe this type of a procedure using neuropsychological test data with strict criteria to classify people into cognitively normal MCI dementia groups as a research classification, not a diagnosis. Because we already know that this idea of a diagnosis of MCI and a diagnosis of dementia is something that's clinical, and that clinical nature of that classification is very important to the people who popularized the notion of MCI. So I think it would be responsible and appropriate to make sure that we use research classification rather than diagnosis in our language when we describe these things. And so what do we have? They used a robust norms approach for defining impairment and thresholds and ranges for the classification of persons according to the MCI and dementia status. This is the same robust norms type approach that Dr. Manley used in her 2023 paper on the HRS HCAP data. We use study-specific tests and batteries and study-specific robust norms to define those impairment levels. And one feature of this diagnostic algorithm is it maintained the selectivity of cognitive impairment in the definition, but not specifically memory. So the cognitively normal criterion, MCI criterion, and dementia criterion might be easier to start with the dementia criterion. To satisfy actuarial neuropsychological criteria for dementia, you had to have 2 or more impaired scores in 2 or more cognitive domains, and functional impairment defined as a FACT score of 6 or more. They had 4 domains and 11 test scores. Their domains were verbal memory, language, attention, executive functioning. Some of those domains had 3 tests, some had only 2 tests. So they only had 2 tests, in their attention domain. The MCI criteria included 2 or more impaired scores in 1 cognitive domain, regardless of the FACT score, or 2 or more impaired scores in 2 or more cognitive domains, and a FACT score of less than 6. Their cognitively normal people therefore had they did not meet the MCI criterion. The robust norms, they used a regression-based approach incorporating robust normative data from individuals identified in the NAC UDS as those individuals who maintain a clinical diagnosis of normal compared across all UDS visits. This was used to transform the raw scores into demographically adjusted Z-scores, accounting for age, sex, education, and race ethnicity for each participant on each neuropsychological measure. A score was considered impaired if it fell more than 1 standard deviation below the corresponding demographically adjusted normative value, Z less than 1.0. I'm going back to my cartoon. Now my cartoon is getting a little more sophisticated, but I still have this central box where I'm grouping people into normal, MCI, and dementia. The y-axis is still increasing cognitive impairment. So this is the number of impaired scores in 11 tests in 4 domains. So you have 0 or 1, 2 or more in 1 domain, 2 or more in 2 domains. And the x-axis is functional impairment. Your FACT score is less than 6. Your FACT score is greater than 6. And your normal, if you have only cognitive impairment in 0 or 1 domain. If you have cognitive impairment in 2 or more tests in 1 or 2 domains, you're going to fall into the MCI or the dementia group. In order for you to have and fall into the dementia group, you have to have a FACT score of greater than or equal to 6, which is more dependence in activities of daily living, and you have to have impairment in more than one domain.
Rich, can I ask a question here?
Yes.
I actually think it's probably better on the last slide. It's about the group that the norms are based on. So you said it's like 317 people. How many is that out of? Like how many, what proportion of the overall sample are those 317 people? And then like how long forward in time is this
I
like
don't
all
remember.
visits approach?
I don't remember.
It's also a selected sample, so that proportion's probably not that meaningful, I guess, but I'm just trying to get a sense of like
Yeah.
how special are these people? Like, are they special or are they just like how selective are they basically?
Yeah. I think that it's an interesting question about how do we think about the normative reference sample, right? Because I think that we want them to be representative of a particular subgroup in the sample we're studying. We want them to be representative of people who don't have dementia, drawn from the population of people where the whole sample is drawn from. We don't want this cut point to be whatever the cut point is. We wouldn't want it to be a good estimate of one standard deviation below the mean in the entire sample. That defeats the purpose. We want it to be representative of one standard deviation, excuse me, below the mean in people who have the same age, sex, education, race, ethnicity as the target person and don't have dementia. So it's a very tricky thing to get used to. It took me a couple times when I was doing this with Jennifer Manley.
So
Yeah, and I mean, I think here, like they have clinical diagnosis, so it's almost easier. It's like you want the people who don't have dementia. We have like a clinical diagnosis. You can just take the people who don't have dementia. But in the instance where we don't actually have like a formal clinical diagnosis, then I think like it seems to become like a lot harder because it's not that we expect zero decline in the people who like there will be some amount of impairment that doesn't meet like even the MCI threshold. And then it's like disentangling those that seems like the most challenging thing to me.
So I'm looking at the paper, the original Graves paper. The sample size was 1,524. And I think you said only 300 some were in the robust normative sample. So they're using NAC. Yeah, 317 were in the normative sample. They're using NAC, which is already a selected sample. I'm impressed that they were that the criteria they applied were this strict.
Right, and
Yeah.
I agree to Emma's point. Yeah, I think I agree with Rich. What you're mentioning exactly. I think their approach to a robust normative sample for this sample was appropriate, but I do to Emma's point about but what does that mean? I think in this group it's tricky, right? Because like Alden says, this sample is already highly selective. Like I published a paper last year showing how just overall across the NAC, they're all very highly select group, older, more educated, healthier, and so because on for the most part, this is all kind of clinic data. They're all clinical type of that data that gets collected from participants going to a clinic and referred by a provider. So then it's tricky it's kind of then wild to think that who are these 317 people who already went to the hospital because something was going on, yet they did not decline. I think like what Emma was saying would be cool to know how long was it that they've been in the study that they were in, because they're already going to be at a higher chance of developing of declining because they're a clinic-based sample overall. So I'm
Yeah.
assuming that these people are going to be even more healthier, right, or highly selected still.
Yeah.
But but their approach to doing it for that sample, it sounds sound.
Yeah. I kind of think that the approach to trying to find a normative reference group within your own research sample has a lot of strengths relative to the alternative, which is to use published norms from Minnesota from the 1990s. Do you know what I'm saying?
Yeah,
Like,
agreed. Yeah.
so I think it offers a lot to researchers. Don't want to just diminish the idea that if you don't have a clinical diagnosis and you don't have long-term follow-up, identifying the subgroup that don't have dementia, so you can classify people as to who has dementia, is a little bit of a circular conundrum. And if we already knew who had dementia and who didn't have dementia, why do we need to develop an algorithm? But besides all those things, it's great. Okay. By the way, these numbers in the cells here, this was the distribution in their sample. So this just goes to show you how special of a sample they had, where 31% come out with dementia, 32% normal, which means the other 35% or so are going to be MCI. That's quite a non-representative sample. So let's see. This is a section on operationalization of the NIA AA criteria, and it's actually the HRS HCAP criteria. So this is that cartoon applied to Jennifer Manley's paper that is in the algorithm developed for the HRS Harmonized Cognitive Assessment Protocol. This one's a little bit more complicated. We have 3 levels of informant-based concerns instead of 2. And these are based on questionnaires that the informant participates with. We've got the IQ code and the blessed, their cut points. We stratify people into concerns and impairment versus no concerns of impairment. We have increasing level of cognitive impairment. This is defined not in terms of test scores, but in terms of domain scores. And these are based on factor analysis procedures. Also used a normative reference sample to define what those cut points were in age, race, ethnicity, sex, and education adjusted samples. The normative reference sample was 1787 on a total sample of about 3,500. And also what this algorithm introduces is self-rated concerns in identifying people as MCI or normal. So someone who has no informant concerns, some cognitive impairment, could be MCI or normal. They're normal if they have no self-concerns. And this is on a single self-rated question. It's on a formal scale. It was part of the HRS core assessment. But if they did have self-concerns, we could count them as MCI. I hate to drag people through critiques on weak operationalizations of the MCI, so I try to find my own papers to focus on when I can. So this was the diagnosis of MCI when I was doing my training. As I was finishing my training in psychiatric epidemiology, we had mild cognitive impairment and severe cognitive impairment definitions. And they were based on the MMSE score. And it's all we needed. And we liked it. And that's how we did it back in the day. And this was from the epidemiologic catchment area studies. And it's really just a categorization based on levels of cognition as measured by the MMSE. There's no norms. There's no functional impairment. It's just low cognition in levels. Here's a paper from Wadley that introduces this thing called psychometric criteria for MCI. And it was baseline performance at or below the 7th percentile. This was in the active study, one of my favorite studies, which I was a co-investigator. And this is so below score on a cognitive measure, a composite cognitive measure on one or more of 3 cognitive tests. Well, it's just low cognition. It's just like we had in the ECA studies in the 1990s. There's no robust norms, no consideration of functional impairment, no consideration of sociodemographics, doesn't rule out dementia. It's merely low cognition. And then here's another paper from my group. And we also defined psychometric MCI. And it was based on neuropsychological test performance, specifically scores less than 2, below the mean, on a single test of memory, or less than 1.5 standard deviations below the mean on a memory test and one other test. And there's no robust norms. There's no consideration of functional impairment. There's no consideration of sociodemographics, and it doesn't rule out dementia, although the study eligibility criteria supposedly ruled out people who had dementia at baseline based on the MMSE and chart diagnosis. But so maybe we can forgive them for that. This diagnosis still has selectivity in memory impairment, and in fact uses different thresholds for defining impairment on memory tests. And it's not really clear why that's important, but that was done. So let's talk about the 2018 NIAAA research definition of MCI to wrap it up. So I think these are the most recent research definition of MCI. It's cognitive performance below the expected range for that individual based on all available information. This may be based on clinical judgment and or on cognitive test performance, which may or may not be based on comparison to normative data with or without adjustments for age, education, occupation, sex, etc. So this is not prescriptive with regard to how you define whether someone's doing below expected range and how you define an expected range. But at least it allows the possibility for using a robust norms type approach for identifying a threshold for which people would be considered impaired. Usually in the impaired abnormal range based on population norms, but this is not required as long as performance is below the range expected for that individual. Evidence of a decline in cognitive performance from baseline must also be present. This may be reported by the individual or by an observer, say a study partner, or observed by a change on longitudinal cognitive testing, or by a combination of these. This decline in cognitive performance may be characterized by cognitive presentations that are not primarily amnestic. Neurobehavioral disturbance may be a prominent feature of the clinical presentation. So we're lessening our emphasis on the primacy of memory impairment and memory decline, adding a little neurobehavioral disturbance. Performs daily life activities independently, but cognitive difficulty may result in detectable but mild functional impairment. So finally, we get this, we're allowed to have MCI and have a little impairment in activities of daily living. Independence and no impairment in daily living is kind of a problem because everybody's got something. And it's nice to have a mild level of ADL impairment. This comes from Clifford Jack and colleagues, published in Alzheimer's and Dementia. Note, no more emphasis on selective impairment, and it's actually quite reminiscent of Barry Reisberg's findings on the MCI concept published in the early 1990s. I encourage history buffs to go back and look at that paper. I said 1990s, but it says 1980s. It's really 1980s. Okay, I think I might stop there. I have some more slides, which is an applied example of how we did this approach in our own study that wasn't an HRS study. But we only have 12 minutes left, and maybe we want to have some time for discussion or questions.
Can I ask you a question? That was fantastic. Thanks, Rich, for sharing and for soldiering through uh despite being under the weather. I'm excited and happy that uh the modern approach now entails assessment or of daily life activities. What are your thoughts about whether we should be focusing on your basic ADLs or your more instrumental activities of daily living? The ADLs versus the IADLs. I know the HRS HCAP algorithm focuses on IADLs and it doesn't really take into account ADLs. What are your thoughts about what we should do?
Yeah, I think that that I think we should be using measures like the IQ code, measures that were developed specifically to characterize the extent to which cognitive difficulties are interfering with someone's performance of their daily activities. I think if you were just sticking with a Lawton or CATS and trying to use that to quantify functional impairment, I think you're kind of asking the wrong questions and likely to get more false positives. That's what I think. It's not really something I've developed a lot of or focused a lot of attention on in studying those measures. That's my gut impact. So things like the FAC, the IQ code, the blessed, these are all things that were specifically designed to try to capture the extent to which cognitive impairments are interfering with daily functional activities. That's where I think we should be using.
Can I ask a follow-up to that?
Yeah.
So if that's the case, then how do you distinguish between informant-rated decline and the impairment in everyday activities? Because those scales are also typically used for informant-rated decline because like the way in which the impairments affect your activities is also the way in which informants observe decline. So then I think those two things almost become the same. I like your point. I agree with it, but then I think it results in this sort of two separate pieces become the same thing.
I kind of think I have to go back and look and see what is it a distinction that's important, right? You're saying those two different things. Is informant-related decline and informant-rated impairment? Is that what we're talking about?
So like in the cognitive criteria for the decline piece, it's either objective cognitive decline based on testing, and Miguel, like step in if I'm getting this wrong, or informant rated decline based on the informant reports, which in the HRS HCAP is operationalized through IQ code, I think.
IQ code or blessed.
Or blessed, yeah. So that's the way, those scales are the way in which we say that informants have seen decline. But then it's the way that which they see the decline is through their impairments because they don't observe their objective cognition. And so that makes the impairments and the decline sort of coming from the same questions.
Yeah, so it's like you can't get to dementia without informant-rated decline. I think that's appropriate.
Right.
right? Or self-rated, I think, impairment as well. Because I think that what we want to avoid is having people who do poorly on cognitive tests being classified as MCI or dementia when they're just people who do poorly on cognitive tests, right? It's trying to identify a pathological condition, not a low performing condition.
I think to add to that, it's some of the issues I think that goes with with this confusion, Emma, because I understand that and I've seen that quite a bit happen because it's just in terms of, well, how are we measuring these ideas, right? Because I think what we're trying to get at with that is from what Rich was presenting, right? There's these two big parts of what it is to have MCI, right? The one of the well, three, right? There's the cognitive decline impairment, but one of them is that somebody's concerned, right? That it's either the self, an informant, or a clinician, right? That somebody said that there's been a change to this person. That's one thing. The tricky part of that is, right, for us, like for the HCAP studies, is the clinician part, right? Because obviously for the ADRCs, the NAC, it's easy because it's like the fact that they're there, that's fine. That could be almost enough. But then the other part is that they don't have dementia, right? And that the not having dementia, at least in that kind of a diagnosis, is really criteria is really emphasized on being independent functionally, right? And so then the problem is, I think, is, well, we have one, the IQ code, right, or something like an informant thing that kind of taps into both, right? It allows us to say like, well, they're independent, and the informant is not too concerned or something, right? That's why we have that range of like, well, as long even with the FAQ, as Rich was presenting, it's not too high, right? But it's not, and hopefully it's either close to zero. So that's what's tricky about that in terms of it's getting at those both ideas. I'm not sure what to do more with that, but I think that's like the issue.
All right. Well, thank you. Thank you for that. Is there anything else anybody wants to ask? Any other questions or points?
I think one thing that maybe is worth coming back to is this idea of like how to identify the normal people in terms of like using the prospective assessments of like, do they retain, like, are they still normal afterwards? And like we mentioned in that conversation about NAC, it was like across all the visits. But I think that brings up a question for me, like where it's like how much long, like how many visits forward in time would someone have to be normal to be like considered normal? And I don't know, Rich, if this came up in your like literature search at all, or if people had done sort of different things. Like I know this is often probably impacted by just feasibility of like when you decide to implement the algorithm. But it seems like, a question that like will eventually need to be sort of addressed is like, what is the optimal number of like amount of future looking or forward looking?
Yeah,
That's
I really only know of two examples in the literature that use this approach. And one of them was that Graves, and the other one was Jennifer Manley. So
yes.
I don't know. That's not a very good sampling base. I don't know if there's more papers out there that have used this robust norms approach. If anybody knows of one, I would be happy to learn about it and add to my knowledge base. But um, it just it I don't think there's a clear answer to that. I think it depends on your study. I think it you do the best that you can. I think you do the best that you can to get the most valid uh, approach you can accomplish within your study and use that. And if you if I say I'm going to use all available follow-up, and I've got a 1-year follow-up. Okay, it's probably not long enough, right? But and so you're going to have some people in your normative reference group who are probably going to go on to develop dementia, right? So that's going to bring down the distribution of cognitive test scores in your normative reference sample, and it's going to make more extreme the cutoff that you would use if you were using a 1 or a 1.5 standard deviation cutoff, than if you actually could know who was truly in that normative reference group sample. So now we have to think through what are the implications of that for who's being classified in your current study.
I can't answer the question of how many other papers or cohorts use a robust norms approach, but I can tell you that we're a couple of us are working on a lit review of dementia criteria, not necessarily MCI, but just focus on dementia. And we've recently whittled our papers down to 550 texts for full text review. So we'll probably be able to answer that question you asked in the next 10 months or so. We'll tell you by Christmas.
I also heard that NIA is updating their criteria, but without in collaboration with AA, Alzheimer's Association. Do you know when they were going to finish that update?
I assume they're developing criteria without biomarkers?
No, without Alzheimer's Association.
Yeah, without the Alzheimer's Association. But so the NIA Alzheimer's Association criteria or at least the proposed criteria were all about integrating biomarkers in 2023. And then in 2018, they also integrated biomarkers. But will the new NIA criteria without Alzheimer's Association not consider biomarkers?
Yeah.
Interesting. Okay.
The recent one presented in Amsterdam at the latest Alzheimer conference was just based on biomarkers. So
yeah,
I don't know other updates, but pretty much they are always working with biomarkers in their criteria.
So
and just to add to Rich's talk, which was great, I don't think, as far as I know, there is really something clear and standardized in ascertaining MCI so far. And I think that is because clinicians do not really prioritize for diagnosis MCI. In many countries, most clinicians are working just to identify dementia, and they're working with diagnosing dementia. And most of the research really is trying to identify MCI as a classification, and it's a very valid point that we should use this as a research classification rather than diagnosis.